Hi, and welcome everybody. I know that the crowd is still coming over from the presidential session, but we're going to go ahead and get started for those who join us online. This is Building Multidisciplinary Partnerships to Facilitate Genomic Testing and Master the Integration of EGFR Targeted Therapy in Resectable 1 through 3 non-small cell lung cancer. I'm Brendan Stiles. I'm the Chief of Thoracic Surgery at Montefiore Einstein in the Bronx, New York, and I'm absolutely thrilled that I was able to convince my colleague, Dr. Stiles Halmos, to come all the way to San Antonio for this crowd of 5 or 6, which will hopefully grow rapidly as the presidential session ends. Balaj is our Associate Director of Clinical Science at the Montefiore Einstein Comprehensive Cancer Center. He's a professor of oncology at the Albert Einstein College of Medicine in the Bronx, and he's a dear colleague and friend, and I think one of the smartest people I know when talking about lung cancer in general, but particularly EGFR-driven lung cancer. So a special thanks to all of our in-person attendees, and particularly to our virtual attendees for joining today. I hope that both crowds will be very interactive and we'll have some great discussions. Thanks to PeerView for providing this educational session, and to AstraZeneca for providing the educational grant for the session. If you haven't already, please take your iPads and complete the pre-event survey, and that would mean a lot to us and help us learn about what we're doing here. Please take part in the audience polling throughout the program in particular, and please submit your questions. We'll answer them during the Q&A session. You can visit us at peerview.com, 2024 EGFR, and see the slides and the practice aid and download everything after the event. So several goals today. We want to augment your knowledge of the role of genomic alterations, including EGFR mutations and match-targeted therapies in resectable non-small cell lung cancer. We hope to improve upon best practices for biomarker testing in earlier stages of lung cancer to guide further treatment decisions. And we hope to equip you with the skills for multidisciplinary collaboration to optimally integrate EGFR-targeted therapies and other novel agents into the multimodal treatment plans of patients with resectable non-small cell lung cancer. And we hope that we'll learn a little something along the way from all of you, and I always learn something from Balaj. So I'll get started a little bit talking about gaps and opportunities for improvement, and I think, often this is, I think, left to the medical oncologist, but I have really advocated and really think that surgeons need to be in this space too. We and the interventional pulmonologists are often the ones doing the first diagnostic biopsies, and sort of getting things going right away, I think, is a critical message that we want to continue to emphasize. And that's important because just like the patients that Balaj treats in the stage 4 setting often have EGFR mutations or other actionable driver mutations, our patients with stage 1, 2, and 3 disease have similar rates of these molecular alterations. In particular, you see the rates for EGFR mutations here. Stage 1, 20%, stage 2, 18%, stage 3, 18%. When I was at Cornell, we studied our patients in the New York City population, which is a pretty diverse racial and ethnic composition. Over 30% of patients had EGFR mutations. So we really see them all the time. It's part and parcel of the discussion in the clinic with my patients that I treat surgically. That said, there's a lot of gaps, and as we've had great targeted therapies move into the early stage space, we have to reflect and think about the gaps that already exist in testing in the stage 4 space. And this is data from a couple administrative databases. There's a MyLung Consortium, Flatiron EHR-derived data, really just showing that we don't do such a great job testing for biomarkers. And this is in the stage 4 space, where we know that first-line therapy is going to be dependent upon detection of these alterations. It's a little bit different with stage 1 disease, where we have time and can do it later, and maybe we'll get to surgery, we're going to get to the most important treatment. But pretty sobering to see that NGS is used only 39% of the time in non-squamous lung cancers diagnosed. If you look for EGFR, which we'll talk about some today, 76%, ALK 76%. To get all 5 of these biomarkers, including PD-L1 that we would think are actionable, less than 50% of patients actually got all those things done in that study. Similarly, you can look at Flatiron and you see that not only, again, is biomarker testing underutilized, you see NGS testing prior to first-line therapy. Really we want to test, but then we want to treat to the test. 31.5% of white patients and just 25.8% of black patients. So we know that disparities exist in biomarker testing as well, which is something that we want to think about, that we work hard to overcome at Montefiore Einstein. And similar to that's breakdown overall, and then the non-squamous, where we would really want to and expect to see high testing rates. You can see again just 36.6%, 29.7% were NGS tested prior to first-line therapy. Certainly we think that would be far from what we'd expect to be the standard of care. So surgeons have a couple roles in this, right? We have a role, and here's some surgeons walking in. I'm excited to see you. Hi, Renee. One role, right, is to diagnose, to stage, and to test, to kick off biomarker testing, right? But then the other role is to get patients back to adjuvant therapy. We've got to safely guide them through the journey of the operative therapy. We've got to do a good operation. In the operating room, we have to find patients eligible for adjuvant therapy, and then we have to get them back to our great oncologists for these medicines that we have nowadays. Remarkably, and maybe it's not remarkable, sadly maybe, we don't do such a great job getting them back. If you look at historical trials, only about 50-60% of patients are able to complete adjuvant therapy. This was one of the most sobering ones to me. This is the Violet study from the UK, Eric Lim. I would argue that these patients are just as motivated as any patients will ever see in the lung cancer space. These were patients who were randomized to open surgery or VAT. So first of all, they had to believe in the idea that open surgery could maybe provide some oncologic benefit to take an open case versus a minimally invasive case. They got quality of life surveys, physical health surveys for a year after the surgery, and so they were clearly engaged, thinking about it, thinking about their outcomes. Yet of patients who were eligible for adjuvant therapy, only about 50% received adjuvant therapy. Speaking of either a nihilism towards adjuvant therapy or the fact that the surgeons didn't do a good job sort of getting the patients ready or getting the patients back to adjuvant therapy. And not just to pick on the UK, and there's data from the US that shows very similar results. The Alchemist trial, if they took patients who weren't put on one of the targeted therapy arms of Alchemist and just looked at did they receive their adjuvant therapy, you can see that only 57% got any adjuvant chemotherapy. And again, these are pretty motivated patients. They agreed to the Alchemist trial. They wanted to look at their biomarkers. They must have heard the story about the potential benefit of adjuvant therapy options. If you look, less than half got 4 cycles of adjuvant chemotherapy as well. So really sobering numbers, I think. And the other thing that really stuck out on this is that the percent of patients that had an adequate lymph node dissection was only around 53%. So not only are we not doing a good job getting them back, there's probably a lot of patients that we don't identify for adjuvant therapy in the first place. And so with that, I'm going to turn it over to my friend and partner, Balazs, to talk about EGFR targeted therapy.
Thank you so much, Brandon. It's really just such a pleasure to be here today. It's great to be invited to a surgical conference and see friends and mentors and close collaborators. I think this is the best time we've ever had in thoracic oncology in terms of collaborating with our friends across the aisle. And on top of that, I had a chance to see the Alamo and actually see the San Antonio Spurs win last night in person from the nosebleed section. So
was Wemby as good as everybody says?
Wemby was okay, yeah. But anyways, great to be here today. And you introduced a couple of sort of disappointing topics in a way, in terms of molecular testing rates not being appropriate, adjuvant treatment not being given. And this is in the context when we talk about stage 4 disease. Over the last 20 years, we've had so much advances in terms of how we're managing our patients with advanced life-threatening non-small cell lung cancer. Now we can test for up to 10 molecular alterations driving very special pathways how we treat patients. We can now use ctDNA technology to complement that. And of course, immunotherapy has transformed the landscape, maybe even stronger in the metastatic setting, where most of our patients now who don't qualify for targeted therapy will get immunotherapy plus minus chemotherapy. The question is no longer, what do we add to chemotherapy? Do patients actually need chemotherapy in a way? But you mentioned, the adjuvant uptake not being very robust. Well, maybe that's not such a surprise because up until a few years ago, we had only adjuvant chemotherapy literature. And let's just be honest amongst each other. Adjuvant chemotherapy really does not work all that well and is quite toxic. If you look at the long-term outcomes of the adjuvant studies, there's a very, very modest benefit that actually disappears over time as a result of secondary consequences of adjuvant chemotherapy. So no surprise that the enthusiasm has been low. But maybe today we can change that a little bit here. So we'll introduce some data that maybe will seem a little bit more attractive than you might think. But before getting into the data, we have a polling question for you. So based on the findings from the ADORA study, maybe some of you haven't heard about it, so you just have to make a guess, 1 to 5. Adjuvant osimertinib should be recommended as standard of care therapy for patients with EGFR mutated stage 2 to 3 non-small cell lung cancer with or without adjuvant chemotherapy, same but only with adjuvant chemotherapy, or stage 1B to 3A with or without adjuvant chemotherapy. Number 4, only with adjuvant chemotherapy, or I'm not sure. I had a friend who always said you have to pick 2 when you have no idea what the answer is. That's the most likely positive one, but let's see. A couple of seconds, I guess.
I thought you picked the longest answer. Is that the strategy?
That's why you didn't make it into medical oncology.
So I had to go the surgery route.
All right, that's a pretty good start. So let's see if we can improve upon on this foundation here. And let's move on, if we can, to our next slide. And this is the study that we'll be talking about. And this is truly a pivotal study. Again, 20 years of advances in the metastatic space. We've been anxiously waiting for the first proof whether precision medicine can break into the earlier stage setting. This study, the Diodora study, tested that question. Pivotal phase 3 double-blind study, taking patients with AJCC 7th edition, stage 1B to 3A non-small cell lung cancer. Patients must have had one of the actionable classical EGFR mutations, EGFR exon 19 deletions, or L858R. If you're not an EGFR aficionado, this is about 90% of all the EGFR mutations that we can find. And as Brandon mentioned, this is a significant piece of the pie. It's about 15 to 20% of your patients in a typical American practice, up to 50% in certain countries, such as in East Asia. So very important patient population to consider. And these patients had appropriate complete resections with negative margins, must have had brain imaging either preoperatively or if not done prior to study entry, and patients were allowed to receive adjuvant chemotherapy as per standard of care, but were not mandated to receive adjuvant chemotherapy, which I think is actually a strength of the study looking back. Patients were appropriately stratified for critical prognostic factors, such as stage, EGFR mutational status, class, and race, and were randomized to osimertinib, 80 milligrams once daily for 3 years versus placebo. And treatment continued up until completion of treatment at 3 years, or disease recurrence, or if the treatment could not be tolerated. The primary endpoint of this study was DFS by investigator assessment. And this study actually was unblinded. It was unblinded early because the DSMC found the data so incredibly impressive towards the experimental arm that they did not feel that it was appropriate not to unblind the study on the level of study data as opposed to individual data. So every single patient continued treatment as per study. They were not unblinded. This is very important to remember. And what's also important to remember that this was HACC 7th and not 8 staging criteria. And this slide just shows you the little shift that, of course, between the two sets of staging criteria took place. And what's most important for this very specific study, that of course most of the original stage 1Bs we might consider now being in stage 2, but the 3 to 4 centimeter category, those patients were allowed in this study. The approval for osimertinib includes those. So you should consider those even in patients where maybe your mindset is not to think about adjuvant chemotherapy, thinking about the magical 4 centimeter cutoff, which actually shouldn't exist for chemotherapy either. So stage 1B is an appropriate stage category to consider based on the data which I'm about to introduce. And this is how the overall patient population looked like for this study. Again, these mutations occur more frequently in patients from Asia. So about 2/3 of the patients were Asian, but 1/3 was more kind of typical American patient population. Stages were fairly evenly split between 1B, 2, and 3A. And about 60% of patients received adjuvant chemotherapy, 40% didn't. Of course, there was a very strong correlation between stage and receipt of adjuvant chemotherapy. Most patients with stage 3 disease received adjuvant chemotherapy, and most patients with stage 1B disease did not receive adjuvant chemotherapy. So here's the first result that we saw now a couple of years ago from an ASCO plenary presentation in 2020. And this was really kind of just an eye-opening set of early results, truly stunning, when we think about this disease-free survival curve separating this broadly with a hazard ratio of 0.2 or so. And the first thing I want to highlight, just look at the placebo arm. These are your patients with stage 2, stage 3 disease, resected, receiving chemotherapy as appropriate. Just look at that survival curve. Almost all of the patients will recur within the timeline of the study presentation at the time, about 3 years. So basically, these patients have practically micrometastatic disease at the time of diagnosis. Very important to remember how poor the prognosis of these patients is without additional treatment. And then look at the experimental arm. that 80% of patients did not have any disease recurrence within the 3 years of this particular presentation. So just dramatic differences. You can push a fire truck in between these curves, to demonstrate the efficacy. Now, of course, one caveat at the time was that, what we know about these tyrosine kinase inhibitors, that they're excellent in terms of achieving remissions, but acquired resistance can emerge. They are more, cytostatic as opposed to cytotoxic. There's always a concern that, well, maybe, early on, we see benefits, but later on, the acquired resistance ultimately emerges, and at that time, it might be more difficult to treat the patients, so we might see these benefits disappearing. And this is what seemed to be slightly substantiated from the first follow-up report of this, now about a year ago, where you can see now longer-term, survival, disease-free survival curve. Osimertinib on the study was given for 3 years, remember, and tried to just match the disease-free survival curve at 36 months and see what happens. After patients stop osimertinib, there's a fairly rapid rate of recurrence in the following year, again suggestive of that cytostatic nature. There's a dormant cancer cell population in some of these patients that can recur as soon as we stop the study drug. So we were slightly concerned, will this impact the overall survival from this study, which is ultimately the most important endpoint that we can think about. Although admittedly, if you think about it, if one of your patients can live 3-4 years without cancer recurring, breaking their spine or damaging their brain, that on its own is actually a significant benefit. Again, here you can see, kind of the same. Again, hazard ratio is very impressive, 0.27, a little bit less than in the first follow-up of this study. And the benefits seem to be across the board. Regardless of the very specific stage. Of course, a little bit less benefit in early stage disease, as there's less risk of recurrence. That's very logical. But whether patients did or did not receive chemotherapy did not seem to make a difference in this particular aspect. And when you look at, again, the very, very important subgroups of patients, you can see that the benefit is, again, for every single subset that we can look at, although there could be some slight differences noted. The patients with EGFR exon 19 deletions seem to do even better than the other critical group, EGFR allele 58R. This is a fun light show that we have here in the room.
We do this at every surgery conference just to test the mettle of the medical oncologist.
Again, now, breaking it down into stages, I would just like you guys to think about the stage 3 patient that you're used to in your clinic and just recognize how with the receipt of adjuvant targeted therapy, that patient population is drastically transformed into one that actually can do well over time, as opposed to very high frequency of recurrences and ultimately demise of our patients with locally advanced non-small cell lung cancer. And adjuvant osimertinib impacts recurrences everywhere, including the very important organ, of course, the brain. And that's as a result of its excellent CNS penetration that we've known about now for 10 plus years. And again, here, if you think about just the CNS-specific disease-free survival, you can just see, again, at 36 months, that's how long patients continued osimertinib. 97% of the patients remained without CNS recurrence-free, 77% in the control arm. That's, again, a huge difference, a 20% improvement in terms of seeing your patient coming back with brain recurrences. Again, there's a drop-off after 3 years, and that's just kind of a teaser. Why do we stop at 3 years? Could there be benefit of continuing the drug for a longer period of time? We don't know that yet, but definitely something that the whole field is considering. Adverse events, here you can see the list between placebo and osimertinib. What I want to highlight is that serious adverse events in terms of grade 3 and 4 are very unusual in osimertinib. Osimertinib is one of our safest drugs. I was just kidding yesterday, you guys are so proud of minimally invasive surgery. Well, this is minimally invasive oncology. Your patient on osimertinib typically would have an occasional loose stool, but really nothing more than you'll experience today after the Tex-Mex dinner that you had last night. Really mild and manageable, and minor skin adverse events. Very occasional, but more significant to remember, pneumonitis risk. Generally speaking, extremely well tolerated, and a very small percent of patients stop study drug over time. In this case, it was 13% in the osimertinib arm, 3% in the placebo arm. So, this is now the most important, slide that we're looking at today. DFS is one thing. I think it's important, but overall survival, that is our most important endpoint that we can consider in medicine. And it was just so impressive and pleasing in a way to see the final overall survival results presented now at the second ASCO plenary presentation by Dr. Herbst a couple of months ago, demonstrating that as much as after 3 years, yes, indeed, there's some more recurrences and the curves are coming together a little bit, but that huge bubble in between the two DFS curves ultimately pushes out towards a benefit that actually translates into an overall survival benefit, and not a minor one. This is a 50% reduction in the risk of death within the 5 years that you can see on this particular overall survival curve. That is humongous. That's about 10% absolute benefit. That's 1 out of 10 patients that you'll see in clinic that you consider the adjuvant treatment that you can maintain disease-free for 5 years. Are we curing these patients? This question has come up. We don't know that. We don't know that whether these drugs cure it, but they delay recurrences certainly to the point that they make a major impact as to how well and how long patients can live without disease recurrence, again, translating into a 10% benefit at 5 years. So these are really, adorable results. I really can't say, in any other way. Very impressed. And again, the chemotherapy question, the benefit is there with or without adjuvant chemotherapy as well. So it's very comforting now, even if you have maybe an elderly patient, maybe a patient, with significant comorbidities where chemotherapy is just not right, you can confidently still offer the targeted therapy knowing that they will derive the benefit from the targeted therapy regardless. Questions came up, could you have maybe not seen as much overall survival benefit or DFS benefit had every single patient received osimertinib at the time of disease recurrence? And that's a totally fair question, but we need to recognize that the study was started at the time osimertinib was just simply not approved in the frontline setting for metastatic lung cancer, even in the United States, let alone in other countries. And at the time that the study was unblinded, the company, the sponsor, actually made osimertinib available to all patients progressing on study. So if you look at the exposure to second treatments upon recurrence, what you can see is 88% of the patients in the control arm, the placebo arm, actually did receive an EGFR tyrosine kinase inhibitor. That's a pretty good exposure. Out of these, about half of them had received the best EGFR TKI, osimertinib. A minor concern about the study, not something that I think at the time could have been fixed, and I think minor enough that it could not have made an impact in terms of the very substantial overall survival benefit that we see. So hopefully I convinced you guys that these are important study results to remember, and with that I'm slightly hopeful that we will improve our polling results here. So again, you have choices going from 1 to 5. And although Dr. Stiles says that we should pick the longest answer, I'm still not sure that's the case, so please go ahead and make your choice.
Yeah, and for those of you who came late, please engage with the iPads and really help us vote. And please, you can ask questions on the iPads, and sometimes we'll push some other sets of questions that aren't going to show up on the polling here for you.
Sure.
This is the same at Tumor Board. Dr. Halmos is always the prima donna, has the guy coming and checking him constantly and taking care of him.
We have many prima donnas in our tumor board. I'm not going to list names. All right, I think we're seeing some improvements. So the key issue is with or without chemotherapy, the benefit is still the same. And do not forget the stage 1Bs, AJCC 7, AJCC 8, 3 to 4 centimeter size tumors still qualify. Actually, FDA approval doesn't even comment on stage, but if you want to go with the study, stage 1B to 3A, 3 to 4 centimeter is an appropriate stage category. So we'll go on, to some other studies here, but I'll take a moment of a break. Brandon, have I impressed you? Are you going to start considering some adjuvant EGFR TKI?
Yeah, I think you have me convinced, yeah. It's part and parcel of our clinic. I mean, we talk about it all the time with our patients, and just the idea that, they want to know. We've introduced the idea to them even before they go to the operating room that they might have a targetable alteration that we would think about giving therapy to.
Yeah, but I think with that you bring up a very good point that I think the earlier you have the information, the earlier you can educate, prepare your patients, the better off, the conversation goes. So early molecular testing, from the first biopsy, guiding patients not just to the best adjuvant therapy, but determining whether they should qualify for some neoadjuvant therapy as well.
100%.
Of course, today's conversation is not about immunotherapy, but especially with the neoadjuvant chemoimmunotherapy literature, it's just such a mandate now to perform complete molecular testing as early as possible.
I'm going to hit you up on that at the end. There's a lot of questions people are asking about that already. It seems to be one of the most important, I think, things weighing on surgeons' mind that we'll talk about some at the end.
Great. Look forward to it. So, of course, this study is highly impactful, practice-changing, no question, but definitely opens up, some new questions that we want to address with clinical studies. And these are a sampling of ongoing important clinical studies between ADORA 2, looking at that even earlier stages of patients. Very likely, that there's benefit there. Is it substantial enough to justify the finances, et cetera? We'll have to see. And the target study now looking at the duration. Is it worth it to continue beyond 3 years? But also looking at now the uncommon EGFR mutations, not just the 90% exon 19 deletions and the L858R. So important studies. I have to say, though, that on the randomized level, though, we will not know the duration of treatment for quite some time. So that's a challenge for our field going forward, and hopefully we'll have appropriate studies to address that in the near future. But moving on from EGFR, I mentioned that in the metastatic setting, we have 10 different markers that the medical oncologist must think about, must test patients for, ranging for EGFR all the way to KRAS and other markers. In the adjuvant space with ADORA, finally we've taken one big step forward. Can we expand the horizons now beyond EGFR? And this is the study that I'm hoping to present now, the ALINA study, now looking at the ALK inhibitor alectinib versus chemotherapy in patients with early-stage resected ALK-positive non-small cell lung cancer. So just thinking about ALK-positive lung cancer a little bit, it's one of the smaller pieces of the pie, but a very important one. It might be maybe about 2% of our patients in our clinics, mostly non-smokers, no gender difference as opposed to EGFR-mutated lung cancers. And these are patients who benefit dramatically from ALK-targeting drugs, such as alectinib, but there's a series of others as well. And these are patients who absolutely do not benefit from immunotherapy. So again, understanding the very specific molecular status guides the clinician in multiple different ways. And these drugs can be so incredibly successful that if you think about metastatic lung cancer, I know in the surgeon's mind, that's a referral to medical oncologists. You don't want to hear about that patient any longer. That patient likely will be dead in a few months. That's no longer the case, especially not in the case of a patient with ALK-translocated non-small cell lung cancer who can respond so incredibly well to these drugs that the median progression-free survival on studies with this drug called alectinib is 3 years, meaning that you can give a prescription to your patient with 35 refills and ask them to return to your clinic in 3 years. That is pretty stunning. Now we do need to generate RVUs, so we do get them back in clinic a little bit more frequently. But just as a guide, just the benefits are stunning. So no surprise, that everybody was eager to move these drugs into now the earlier stage setting. And this study now is asking really a revolutionary question. Do we actually need chemotherapy? This study does not allow adjuvant chemotherapy. This randomizes between chemotherapy or best platinum-based doublet chemotherapy versus alectinib. It's 2 years, so shorter duration of treatment, a little bit more complicated drug to take, 600 milligrams twice daily, but just as safe. These are incredibly safe medicines that we're so lucky to have. You can see the basic study criteria, primary endpoint being disease-free survival. And here you can see, again, just stunning results when it comes to disease-free survival benefits. Hazard ratios very similar to the ADORA study, 0.24. Again, easily, that monster truck here in Texas could be driven through. And again, just think about it. If your patient you operated on, you gave the best chemotherapy to, within just 3 years, half of them will recur with the conventional treatment path. Just look at the alectinib arm, and somebody's pushing my slides forward. Please don't do that. Just look at the alectinib arm and look at 3 years. This is actually a year after they stopped the study drug. 89% of them, 88% of them are alive without disease recurrence. Again, just think about your average patients from the past, stage 2, stage 3 disease, and how much this is a different era. And again, must question whether there's actually a need to give chemotherapy to these patients in reality if you can do this well just with targeted therapy alone. Too early yet to have overall survival data, but in the expectation and follow-up of the ADORA studies that we certainly will, and definitely practice changing. But now I'm unable to move my slides.
Let me see.
It seems like somebody got so stunned with the results that we just can't move on. So similar to osimertinib, this is a drug that actually has great CNS penetration, and that's nicely shown here. That again, CNS recurrence, patients coming back with brain metastasis, the percentage of them is so much smaller with the targeted drug alectinib. Can we just move back one slide?
You guys able to go back a slide? We've been hacked.
Okay.
Yeah.
So again, just think about it. 2 years of alectinib at the 2-year time points, only 1.5% of the patients have brain metastasis. Look at the chemotherapy arm, 15%. 1.5, 15%. And what an incredible difference this makes for your patient who could recur with a large brain met, leptomeningeal disease, potentially fatal recurrences. Just demonstrating this incredible benefit of alectinib. It's not FDA approved yet, but I believe in the next couple of weeks a decision will be made. The drug is available, and we are talking about this already with our patients, and most insurance companies are willing to look at this very important information and allow our patients to benefit from the drug. So it's important to consider it from the ESMO presentation on. And this is presidential election year. I might say I don't know about who's going to be the president, but alectinib should be elected. Yeah, that's for sure. So I will vote for that. And with that, if you could move to the next slide. So now we spoke about the adjuvant targeted therapy, EGFR and ALK, two incredible advances of our field. How about neoadjuvant? Could we make an impact in that particular space, especially for patients maybe with more bulky, locally advanced disease who could benefit from tumor reduction prior to surgery? There's been a couple of studies done. They are a little bit less impressive than we might have hoped for. But now a pivotal one, NeoADORA, if you understand correctly, has been completed in terms of accrual. So we should be seeing the results sometime soon. This has 3 specific arms: neoadjuvant chemotherapy alone, chemotherapy plus osimertinib, or osimertinib alone followed by surgery. And we're very eager to learn how this might translate into our practice afterwards. And next slide. And the train moves on. EGFR is just one particular subset. There's a lot of other studies looking at other patient populations with ALK translocated lung cancer, with BRAF, maybe with MET, large international efforts. So we're definitely very hopeful that we'll learn a lot and we can impact patient care very soon, even more dramatically. Next slide. All right, and I think with that, we've covered all the dry data, and hopefully we can cover a couple of cases, but it sounds like you guys will need to take a little bit of a break and get to some work, answer some questions.
Yeah, absolutely. Thanks, Balazs, for going through the data. Next, we'll have a couple cases that I hope to get some interaction and get some thought from people in the crowd too, as well as rely on Balazs's expertise. But they will be pushing some other questions to you on the iPads, and so if you get a chance to go ahead and answer those, that would be great as well. You want to go to the next slide? So we're going to go through a couple cases, I think, and get some input. And there's lots of good questions coming in related to timing of testing, use in stage 1 that I think we'll cover a little bit in some of the cases. And so let's see what we can do here. Next slide. All right, so a 56-year-old Spanish-speaking female, as is typical of many patients, found incidentally, right? She's at 56. She's really a light smoker. She wouldn't have been screened, but showed up in the emergency department with abdominal pain and had a CT of the chest and abdomen. No real other significant medical history. Next slide. And this is what they found. She has this sort of apical oblong lesion, which on CT was 2.3 by 1.5 by 2 centimeters, spiculated. And she had a little small adjacent nodule. You can see it there to the right of the larger nodule. And interestingly, she had a couple little scattered things here and there. It's not that unusual. I think we had looked once and we see other little nodules in maybe half of our patients and never quite sure what to make, but really nothing bigger that caught the eye. Next slide. So she was eventually referred into our lung nodule clinic, and she got in addition to the CT, she got a PET scan. She had some pretty significant uptake in the upper lobe lesion of 10. All the other little nodules really didn't have much uptake, but again, really none bigger than 6 millimeters or so. Got a brain MRI, which was negative, and obviously had excellent pulmonary function and great performance status. Next slide. Okay. So what would the group recommend to this patient? It's a peripheral lesion, but so should we do a CT-guided biopsy? Should we do a navigational bronchoscopy with EBUS to try to get the nodes? Do you see any indication for nodal staging here? Apical looks like an easy wedge. We could just wedge it for diagnosis. Or should we start with a sublobar section, just start with lobectomy because of the size of the lesion? And I'm sure that no surgeon will say, I'm not sure. So go ahead and take a vote. Never in doubt. So most would do a navigational bronchoscopy with EBUS and some a CT-guided biopsy. It's interesting, very few would go to the OR for wedge for diagnosis. I think that practice has definitely changed. What do you think, Balaj? Sometimes you guys are the gatekeepers for these patients, right? Lung nodule, PET avid, they might send them to you. What do you do? How do you do it? Do you get your surgeons involved early? Who do you go to?
Well, I typically go to our tumor board, which I think is an incredible resource, and I just love it. That's the best part of our week, I have to say. We have to extend it from 60 to 90 minutes each week because there's just so many challenging cases and so many great discussions. But I find that that's the best forum where all the right expertise is brought together between radiology, looking at some very specific anatomical aspects, pulmonary telling us about what they can do. So I think that is the right place to discuss. But I have to say that sometimes we make mistakes, maybe due to feeling rushed or the patient being in a particular setting. Like many times if our patient gets admitted, the medicine team will just get a CT-guided biopsy, and then a week later we scratch our heads like, PET scan hasn't been done, the PET scan might show something else, and maybe in that case we could have done a bronch and an EBUS. Patient could have had one procedure as opposed to two. So I think systems-wide, we have to start thinking about how to impact care. For such a case, certainly what we've seen is that, the navigational techniques have improved just so much. Sometimes we're just stunned in tumor board where we look at some tiny peripheral nodule, hiding between 3 vessels, and the pulmonary guys are able to kind of drive the needle in and give us a diagnosis. And on top of that, do a careful sweep of the mediastinum and sample, knows that, might not even look suspicious on either CAT scan or PET scan. So I think there's a bit of a push towards bronchoscopy being the better technique, even for the more peripheral challenging cases, just given how much the technology improved. But honestly, I do rely on you guys, the tumor board, surgery, pulmonary radiology, putting their heads together. The medical oncologist just stands back and, we need a tissue diagnosis, right?
Yeah, and it's interesting. I have to confess we don't present all of our stage 1s, obviously, to us at tumor board. It just would take too long to get through. But I do think that idea of multi-D discussion and having, the pulmonologist besides you guys there in clinic. How many in the room routinely use bronchoscopy, navigational bronchoscopy for all biopsies and have gotten rid of CT-guided biopsy? For the most part, like 80% plus. Many? Next slide. So we did the same, and as Balaj laid out, we really have a great IP team, so bronchoscopy was performed. Interestingly, in this case, they couldn't get to the lesion, and this was before they had all of our fancy tools, but they did get level 11, 10, 4, 7 negative. So given that, rather than put the patient through another biopsy procedure for a suspicious lesion, we took this patient to the OR for a diagnostic wedge resection, and then ultimately a completion lobectomy. Next slide. Because the path showed frozen adenocarcinoma in the operating room. And then because of the size of the lesion and her age, we did a completion lobectomy. And the final path was interesting. It came back, the primary lesion was 2.2 centimeters, and it was a relatively well-differentiated invasive adenocarcinoma. And then there was a second non-dominant nodule that had more of an appearance of a minimally invasive adenocarcinoma. And then interestingly, it had two separate EGFR. Obviously the question would be raised, is this intralobar spread? But we were able to get molecular testing on both. And this is something I wanted to ask you, Balazs, and something that we often talk about, and you kind of alluded to it, are all EGFR mutations the same? We see these reports, we see all these numbers, trying to understand, is it different? If we just see EGFR, should we pull the trigger on osimertinib? Or how would you think about something like this with two different EGFR mutations? And what is that second EGFR mutation?
Yeah, I didn't realize that you were going to challenge me this much. But number one, EGFR mutations come in different categories. So the classical actionable ones are exon 19 deletions, L858R. That's 90% of our cases. The rest of the 10% breaks into two major categories. One is called exon 20 insertions, and they need to be approached very differently. Now there's a bispecific antibody, amivantamab, which is approved and is moving into frontline with chemotherapy. Certainly not something that's ready for the adjuvant space yet. And then there's the uncommon EGFR mutations. And the second cluster, G719C and S768I, ends up in that particular category. And in fact, many times happen together. These are so-called compound mutations, very typically happening together. And they would make the patient a good candidate if the patient had metastatic disease to treatment with either afatinib, which is the approved choice, or osimertinib, which is not particularly approved for these mutations, but seems to have similar activity. So it's dealer's choice in a way, which one you pick. But in this case, what was the real challenge is that you pursued molecular fingerprinting, which is kind of an evolving theme. And we use it from time to time, and it can be very helpful. The problem is that we don't have any guidelines, in our field as to how to actually put that into practice. So we many times just scratch our heads. Okay, the patient, one tumor had 10 different mutations, the other one 12. How many match? Does that qualify as the same tumor or not the same tumor? I hope that we'll have guidelines from molecular pathologists soon enough. In this case, though, these are two very distinct, very identifiable EGFR mutations. They really seem to suggest that these are two different primaries. Why is the patient predisposed to them? I want to challenge the field. We actually don't understand, the molecular basis of EGFR mutated lung cancer. There's been interesting data from, Charles Swanton's group in terms of environmental damage, but I'm sure that there's still more to learn. And especially such a patient, why would she be predisposed to multiple? Who knows? But I think they need to be treated separately when it comes to adjuvant discussions. The uncommon mutations don't fall into the ADORA study conversation as of yet. The other one is kind of borderline-ish.
Yeah. So it's interesting. I remember this lady's discussion at Tumor Board Well, and I was really strongly staking that these are different mutations. We don't need to do anything. One was a minimally invasive. And she had these other little nodules that were really distracting people, and people were talking about that a lot. But I was thinking I was protecting her from the oncologist and saying, we don't need to give this lady adjuvant. I've cured this lady. I felt pretty certain about that. Next slide.
How many years ago was this?
Just 2.
Okay. Can we discuss this case again in 3?
Yes. Well, no, we're going to discuss it. It's going to happen pretty quickly here, actually. So what would you recommend for this patient next? So she had a stage 1 resected. We think we've definitively shown that she had just 2 separate stage 1 lung cancers. Thank you, sir. So go ahead and take a vote and see what everybody says. And this actually gets to one of the questions somebody asked, would you use adjuvant osimertinib in a stage 1A EGFR positive patient, Balazs? And after we see what the audience says, I'll ask you that question. This lady had a really sweet daughter. They would come to the clinic in matching T-shirts all the time. They're really funny. So a lot would give adjuvant osimertinib here. Some would even give chemo and adjuvant, and I guess we didn't have none as one of the choices, or maybe nobody said none. So what do you think about that stage 1 osimertinib? The surgeons are being pretty aggressive here.
I'm glad to see such an excited group of surgeons, that's for sure. I'm surprised that you didn't put in just observation alone as one of the options, because it would be appropriate, I think, based on all the workup that you've done. You spent $10,000 on molecular fingerprinting, and now you're not using the information.
You can't say it costs that much.
But anyways, yes, there's a couple of sort of high-risk features, I guess, with the multiple nodules and everything else. So I think adjuvant osimertinib is fair to discuss. Chemotherapy, I would have zero enthusiasm for it. In a node-negative case, EGFR mutated, where you have the targeted choice instead, no. I think observational adjuvant osimertinib would be two fair discussions. And I think this is where, shared decision-making is so important, where there's no clear guideline, for this very particular stage, the multiple, primary tumor setting.
All right, this one's still not clicking for me. So next slide. So, I thought I'd done well, but we didn't pursue any adjuvant therapy. We thought these were separate. She came back for a 6-month interval CT scan, and all of a sudden, these little nodules, which had been really faint, a couple millimeters, she had multiple nodules like this that were sort of 6, 7 millimeters, some new. You can see a few of them highlighted there. And we got a PET scan and tried to sort of understand it. And they had mild to moderate uptake, again, pretty small nodules, but some appeared to be avid, and you could see this sort of distribution of nodules. So now what? I was a little worried, but should we just continue to observe? They're pretty small. Could we do a liquid biopsy, bronch, surgical biopsy? I'm not sure.
Reacting to the crowd or me?
Crowd first. I'm going to hear the crowd before you weigh them with your trickery. Can you guys play the music? I find that more soothing. Thank you. And this was a case we talked about at Tumor Board a couple times too, I think. I like it. So lots of people thinking about, let me see what the next slide is. Can I see the next slide real quick, and then we'll come back to this for a second. Next slide. Can you go back for a second, though? So we did actually, it's not fair if you go back to the last, we did do a liquid biopsy, just wondering, and it was negative. A couple have asked here, what's the role of liquid biopsy, in your opinion, for early stage EGFR-driven lung cancer?
Yeah, great question. As I mentioned at the start when we had like 2 people in attendance, for metastatic non-small cell lung cancer, liquid biopsy testing has become huge. It's an incredible complement, for tissue-based testing. We can expedite the completion of expanded molecular testing, start patients on proper therapy. But liquid biopsy is still, challenged by earlier stage cases where the yield is just not high enough to have full confidence in it. And what happens is if the ctDNA that you send is positive, credible information. If it's negative, you have no idea whether you've ruled something out or is it just an assay that you kind of wasted. So it's really not ready for prime time for early stage lung cancer in terms of helping diagnosis, helping management. Let's say a patient, you're thinking about neoadjuvant, the biopsy didn't have enough tissue for molecular, can I start to send ctDNA? Really not the right approach yet. But in this particular case, I actually had a very identical patient. ctDNA suddenly, now you have a patient with likely metastatic disease, right? You're looking at multiple lung nodules. This is now, first of all, proving that the patient has recurrence, has metastatic disease, and confirming that you can go on with targeted therapy. ctDNA here suddenly have a little bit more of a yield, and I had an identical patient where we could save the patient from the biopsy, prove recurrence just by the molecular marker in the bloodstream. Again, in that case, it was EGFR mutation. In your case, it sounds like you did the right thing by sending the liquid biopsy to see if you might avoid a resection, but it just didn't have enough yield.
So she had pretty peripheral nodules, and we just took her to the OR, and I wanted to wedge out a couple since she had the different EGFR mutations the first time. And so we got a left upper lobe wedge and a left lower lobe wedge, and they looked the same as the original histology, and both came back with EGFR 19 deletions, consistent with the dominant lesion on the other side. So let me come back to that. So what do you think about this? I mean, a couple of the questions, metastatic disease almost seemed to be pre-existing disease that sort of blossomed after surgery. Osimertinib now, osimertinib plus chemotherapy, just how do you think about this type of thing? And Somebody in the audience raised a great question. You just showed the Alina data that showed you don't need chemo, so do we need chemo here for this disease? Now it's stage 4, we might not use chemo.
Well, now it's stage 4, so now we're going to follow the literature supportive of treatment choices for stage 4 disease. And up until a few months ago, the standard answer for a patient with EGFR exon 19 deletion positive disease was osimertinib. Osimertinib alone, excellent treatment, very little side effects, very high efficacy, median progression-free survival of just around 19 months. Terrific choice. But the last couple of months, we've seen now a couple of studies trying to offer combination strategies up front with the hope of delaying progression even further and hopefully impacting overall survival even more significantly. And 2 of those studies read out, and both of them are positive on a certain level, but both of them are posing challenges as to practical implementation. And I think for thoracic surgeons, this is like, I just want the medical oncologist to take care of it. So I'll try to be brief. So FLAURA2, adding chemotherapy to osimertinib definitely shows an improvement in progression-free survival. At the same time, patients need to suffer all the side effects of chemotherapy, and there's no overall survival benefit yet. There seems to be a special benefit for patients with CNS disease. Now this patient might need to get a repeat brain MRI, as you just documented metastatic disease. If the patient had CNS disease, we might consider adding chemotherapy. The other choices now, the bispecific antibody amivantamab I mentioned, anti-EGFR MET, alongside an EGFR TKI, in this case lazertinib, which is near identical to osimertinib. Again, a significant progression-free survival benefit with this combo, early trends for an overall survival benefit, but it's a significant package for patients to take. A lot of side effects in terms of gastrointestinal and dermatological side effects, infusion reactions, and even more concerningly, a 40% risk of thromboembolic events, calling for at least 4 months of anticoagulation. So it's just a big package, for patients to take. So we're waiting, for more data on it. So osimertinib alone for your patient, as long as the brain MRI is negative, would seem like an appropriate choice.
Fair, yeah, and it was negative, and she actually continues to do well with good disease control. All right, case 2, a 61-year-old male, again a never smoker with asthma, presents for evaluation of left lower lobe mass. Dry cough for 2 years. He presented again to the ED with a cough and had a 3-centimeter density of left lung base concerning for malignancy. One imaging they measured out on another at 4.1 centimeters and recommended tissue sampling from the ED. He got a PET along the way. This is outpatient workup and had an SUV of 12, but really nothing else in the nodes or in the brain MRI was negative. So what do you think for this patient? Would you handle this any differently than we did the first? Diagnostic wedge, it's peripheral, but it's a little big. CT-guided biopsy because it's peripheral. Nav bronch with EBUS. And it raises the question of do we do, and practice of people in the room, do you or your interventional pulmonologist do routine lymph node stage and even for PET negative nodal stations? So if everybody could answer. And I remember when this patient presented, it was one of my partners, Dr. Vilma Ratanas, we were gung-ho to try to get this patient on our neoadjuvant trial. And so we really wanted to stage the mediastinum and see if there were any nodes. We're thinking even just based on size, we might enter this patient on the trial. You're not getting it? Maybe we'll go to the next. Thank you for speaking.
The poll is not going through.
Thank you for speaking up, Dr. Sarkaria. Did you get it now?
You could have wedged this lesion out in this period of time.
Indeed. This is why we sometimes just do the wedge. Okay, any results? If not, we can. Yes, the same pattern here. And I'm interested to see how many of you or your interventional pulmonologist sample nodes with, even if they're PET negative, how many of you have routinely sample nodes? Yeah. I still cannot get this clicker to work. It wants to work. Can you go to the next slide? Thanks. So we did do that. We got an adenocarcinoma in the lesion. And the 10L, this little small node, I think it was 5 millimeters, was positive for malignancy. So stage T2B-N1, stage 2B. So we're ready for some potential neoadjuvant therapy. So what would you all do next for this patient? Can you push the poll to them? OR, it's N1 disease, right? We can take out stage 2 disease. We can cure those. We don't need these medical oncologists. Maybe we'll give a little neoadjuvant chemotherapy and immunotherapy, further testing, not sure.
Looks like they're not getting the right set of questions again.
Are you guys on the previous question? The slides are still advancing even without me. Somebody in the next room must still be doing their thing. So, do you guys have results for this poll? Not working? No. It's okay. They're shaking their head in the back at me saying, move on. Okay, so obviously the missing part of this, right, was the molecular testing. It was a never smoker, but we try to do this for all of our patients, particularly if we're thinking about offering neoadjuvant immunotherapy. And so Balazs talked to us about strategy for that, and there's a ton of questions about how quickly can tests be obtained. Should we get it all? What's the acceptable time to order and conduct EGFR tests in early stage disease? For this exact reason, right? We're under pressure. We want to get this patient treated. They want surgery. We're thinking about neoadjuvant therapy. What are the timelines? How should we test? Should we test everybody? Should we just test never smokers? What do you think?
Well, we should test everybody. Actually, I failed to point it out in the ADORA study that I think 30% of the patients were smokers. Just because somebody smokes, they are not protected from illnesses that non-smokers can get. So everybody needs to be tested for this complement, at least PD-L1, EGFR, and ALK present in the earlier setting. Many institutions will say that if I have to do 2 molecular tests, it's just easier for me to run an NGS, and I think the NGS will provide more information for the clinician as to the other alterations. Now, what's the right time frame? In the metastatic setting, the guidelines suggest 2 weeks or less. 2 weeks is reasonable to accept, and it's definitely not easy for institutions to come up with a pathway where the pathologist can comfortably sign out, the tissue and can get enough in time to the molecular pathology lab to complete all the testing within a very short time frame. So I would say 2 weeks is probably a reasonable guideline here as well. And I think, we all do our best to achieve that. And I think nowadays, mostly we do it, at least in our practices.
Yeah, for sure. So, as we're thinking about this, well, hopefully you'll be able to answer this, because I want to ask Balazs what I think. So you got a lot of options with this patient, right? Lobectomy adjuvant, should we do some neoadjuvant? Should it be immunotherapy? Some EGFR patients got included in the trials. Should we neoadjuvant chemo alone? We know the patient's going to need some chemo. Should we give neoadjuvant osimertinib? And tell me, Dr. Chudgar, are you getting the poll question? What'd you say? Get the snappy music back. So what do we get? I think everybody's... Yeah, nice. You can see how controversial this area is, right? Lots of different options and all potentially reasonable, I think. Balazs, do you have a preference here?
I do. The patient does have an actionable EGFR mutation, so I feel uncomfortable with the neoadjuvant chemo immunotherapy plan, especially, not that it could not potentially help, but it could possibly harm the patient afterwards who could benefit from the adjuvant osimertinib. We're starting to understand that there's very particular adverse events that can happen with higher frequency if somebody had been exposed to immunotherapy and then gets put on osimertinib. So
the Keynote 671 EGFR patients seem to do well. What do you say to that?
They seem to do well, but they do incredibly well in the ADORA scheme. So there's no reason not to stick with ADORA in this particular patient. So the neoadjuvant I'm uncomfortable with. I think the others, that incorporate osimertinib one way or the other, you can potentially consider. But the more conventional would be in this case just resection and then adjuvant therapy.
And how about a couple people asked about neoadjuvant osimertinib? Is it ready for prime time? And one interesting question that's a little bit off topic, but mechanisms of resistance, are they different in early stage versus metastatic disease? And does our sequence of therapy affect that? Is there any evidence to suggest that?
Well, in terms of neoadjuvant, it's not ready for prime time. I think for individual cases where there's a strong belief by the surgical team that neoadjuvant reduction in terms of tumor burden can impact the surgical approach, I think it's appropriate to offer, but it's not based on high level of evidence as opposed to the adjuvant use of osimertinib. So in this case, the adjuvant chemo and osimertinib is a great sequence, to offer. As to resistance, I think we're actually still learning, from the ADORA study and other experiences as to what, the acquired resistance mechanisms will be. I don't think there's any real expectation that they will be all that different from what we've already learned in the metastatic setting, and those are very specific. There can be secondary mutations of the same EGFR pathway. Now there's fourth generation drugs being developed to overcome those. It can be bypass mechanisms such as amplification of MET, combination EGFR, MET inhibition can be successful. It can be small cell transformation, which actually ends up being a tragical outcome for most of our patients. We offer small cell type treatment for those patients, but admittedly the benefit is very limited. And there's still a group of patients where the acquired resistance mechanism remains unclear.
So this patient did great. Dr. Moratana took him to the OR, did a robotic lobectomy. 1 of 17 nodes was positive, got adjuvant chemo, carboplatin, and adjuvant OC. And so I think that's it. There's going to be some questions at the end that we'd love to ask, but then if there's any questions from the audience, we would love to get some. Avail yourself of Dr. Halmos to ask any questions. And if there's any, you can also push some virtually to us as well. We've got about a minute or so left. Any questions out there? I can't remember. There's summary question. Yes, please.
I guess the dose which is used is 80 milligrams. Is it not for the ADORA trial?
80, yes.
And if patients develop side effects, severe side effects, and I had 2 patients with skin reaction, one of them, the medical oncologist reduced the dose to 40 milligrams, and another patient, even that didn't work and he had to stop it. Now my question is, the reduction of the dose, do we have data on that? Is it as effective or not effective? Should we try it, or if the patient develops side effects, we should stop?
Well, there's certainly no high-level data in the adjuvant setting as to how dosing makes a difference, but we have a very high level of comfort in the medical oncology field as to appropriately dose adjusting and maintaining that dose in a way that these side effects that could be impacting quality of life could be minimized. There's been multiple papers in the metastatic setting to suggest that patients with significant side effects, reducing the dose actually doesn't compromise the outcome, and I sort of believe that most likely those will translate into this setting as well. I'm sorry to hear about your patients. Again, osimertinib, generally speaking, is actually a very, very well tolerated drug. I have to admit, though, that in the adjuvant setting, patients seem to be willing to tolerate these side effects less than when they face metastatic disease. So that shift we've seen in terms of mindset, and that might be very, very appropriate for patients where maybe the benefit is not so clear after surgery, whether they have to take a drug or not. If they have side effects, they might just think about stopping as opposed to when you have metastatic disease.
Other questions? All right, great. Oh, Gavit.
My question is, hi, Gavit Woodard from Yale. My question is, with the ALENA data in ALK showing how the adjuvant chemotherapy, wasn't even given, if you think about the ADORA data, and it was dealer's choice from the oncologist as to whether or not patients received adjuvant chemotherapy, so obviously some selection bias to the groups who received it versus those that did not in ADORA. Now that we have other data showing just the benefit of adjuvant targeted therapy alone, does that make you less prone to give adjuvant chemotherapy in an EGFR mutant patient?
Yeah, that's an excellent question. And first of all, congratulations on your beautiful award from this morning. So yes, indeed, I think we need to recalibrate for whom we offer adjuvant chemotherapy. I would think that the targeted therapy is the more important foundation in my mind. And if you think about these survival curves, what extra benefit do we anticipate from adjuvant chemotherapy when somebody has an 85% 5-year survival? We know that the relative absolute risk reduction in terms of chemotherapy is in the range of 10 to 15% relative. That could translate into a 1% absolute risk reduction for a patient on adjuvant targeted therapy. Is that worth it? I would start having discussions with my patients. Maybe end to disease, I would still push it. Node negative, forget it. In between, I think it's a fair discussion.
Especially in light of your comments about how patients are less likely to tolerate side effects when a
Yeah.
therapy is given in the adjuvant setting versus for metastatic disease.
Dr. Woodard, what's your practice at Yale, the group's practice in that situation? For chemo versus chemo OC? I mean, OC versus chemo OC?
Again, it's luckily a decision I don't have to make. I would refer them to oncology and the oncologist discuss it with patients, but I think patients prefer the idea of not taking chemotherapy. And even from a surgeon perspective, as much as we're prefacing our early stage patients saying, oh, this is part of a multidisciplinary team approach and you're going to need potentially some sort of additional therapy depending on what mutations might be. Patients want to be cured after surgery and they want to be done. And so I think they don't like this idea of like, what, you said you got it all and why would I need additional therapy now? So I think patients are more into the concept of not being on chemo.
Yeah. Completely agree.
Agree comments. And again, it's a fluid, field in a way. And there's some kind of conventionalists, who want to stick with the adjuvant chemotherapy as we've done it for 40 years. But I might say the Alina trial, the evidence-based approach is not to give chemotherapy. The experimental arm had no chemotherapy. Why wouldn't we just stick with, what's the evidence? And giving chemotherapy actually delays your ability to give the more effective adjuvant treatment. So actually shifting, from the study design, you could compromise care. So that's something to consider as well.
I have one other question, or comment, really. This is about biopsies and testing. We at our group, we're very heavily going the bronch EBUS route just for one-stop shopping for the patient to get a diagnosis and sample the lymph nodes. In the first case you showed where there are two separate nodules, and in my mind I was like, oh, this is going an immunotherapy route. When we are thinking about clinical trials in our patients, it actually is kind of useful to have a CT-guided biopsy first, get a diagnosis, and then you can approach the patient for this additional, now we need an EBUS, and we're going to have to get more tissue, and it allows us to collect a second set of samples for tissue diagnostic purposes, which is useful for in-house research as well as things that might be required for clinical trials.
I think it's a great point. I think it's a great point for your fancy patients at Yale. It's a little hard to get our patients sometimes back for a second biopsy, so I think it really does need to be taken in the context of the individual patient. For us, scheduling challenges a patient and getting them through in a timely fashion. I know they're already facing a long neoadjuvant process. If we can do it in one step, it's important, but I appreciate, in the perfect world, if you could have the discussion, have why, get tissue for research to answer all these questions. I completely agree.
In the Bronx, I think our patients will think the second biopsy might be a valid biopsy.
Very true. Very true. All right, well, thanks so much for everybody for coming and for spending the lunch with us.